Thank you. Our next conversation will be on antimicrobial resistance, and I'd like to welcome on stage our speakers, Dame Sally Davies, who's the UK Special Envoy on AMR, Anandkumar, who's the co-founder and CEO of BUGWORKS, and Ramanan Laxminarayan, who's the founder and president of One Health Trust. Thank you. So AMR is often described as a silent pandemic, but it feels like it's having its moment in the sun right now. There's so many discussions around AMR happening at UNGA, and there's going to be a high-level meeting on it on Thursday. So I'll start with you, Sally. Do you think AMR is actually coming to the forefront at the moment, and what needs to happen in terms of policy now?
I do think it's coming to the forefront. It's the second high-level meeting. We've got vastly more side events and awareness. What I worry about is that it'll fall off the agenda straight after the meeting. And it shouldn't. Antibiotics are the infrastructure of modern health systems. They're the infrastructure for food systems, and both of those are at risk across the world. And if you look at the new data that we published last week, the GRAM study, by 2050, 39 million or more will have died of AMR on the present trajectories. So we've got to do something about it. We've got to make sure that people protect what we've got and they have access to what we've got, let alone the rest of the story. So please help us keep it on the agenda.
Well, we're certainly trying. We've been speaking so much about AMR at Devex. I think we've got like 3 or 4 stories out this week, which is unheard of. And I hope we will make an effort to continue to talk about it a little bit more.
Because there are lots of human stories. Even I have been working on this for well over 10 years. My goddaughter died 2 years ago of AMR. If you ask people, most of them have known a case. Think about cancer. 1 in 4 cancer cases gets a really serious infection, and AMR is killing plenty of them when their cancer was cured.
That is true. I think the Africa CDC published a report that says that AMR is now killing more people than HIV, malaria, and tuberculosis combined. But Ramanan, I want to come to you because something has to happen, as Sally said, but it takes a wide range of people. So how do we make sure that there's this collaboration and multi-stakeholder approach in addressing AMR?
Thanks for that question. Thanks for having me. And I think you started by saying it's a silent pandemic. I don't think it's silent at all. I think a lot of people are dying, and they know that they're dying. We just don't add up those numbers in the way as Sally just said. 7.7 million people die of bacterial infections every year. 7.7 million. About 1.4 are directly, or 1.3 are directly attributable to drug-resistant infections. A lot more people die because of lack of access to antibiotics than do of drug resistance itself, because a lot of people are just not getting access to even antibiotics that you would not die of those infections here in the US, but you would die of that if you were in Nairobi or in Johannesburg. So that's just because the drugs haven't made it out there in those places, not a problem that's unfamiliar to people working on HIV or TB. I think there are 3 things that need to happen. First is a lot of those infections are preventable. We have those infections in many LMICs because we don't have the levels of water and sanitation, of immunization and infection prevention control that we could. If we did that, we could avert at least probably 750,000 deaths, probably more than that, even just from the prevention part. We need access. If we have access to drugs that are fairly inexpensive, and remember, we're only talking about 5 days of treatment. You're not talking about lifetime treatment. We could avert literally millions of deaths. The third is, whether in rich or poor countries, every time we use antibiotics, whether inappropriately or appropriately, we're generating drug resistance. That's just how things work. That's how evolution works. So we're always going to need new antibiotics unless someone has a really good idea about how to not have antibiotics and make the medical system work. No one's figured out a way to do that quite yet. So we're going to need access to those new antibiotics as well. But first, those antibiotics need to be in the pipeline. And I think you'll hear again from Anand, it's very hard to develop new antibiotics. It's a very difficult business to be in. And beyond just developing the drugs, you also need to get it into patients wherever they might be. So we need these 3 things. And that's what you'll hear at the UNGA high-level meeting on access to effective antibiotics tomorrow.
Thank you so much. And you spoke about developing new antibiotics and how difficult that is. And Anand, you can definitely speak to this. I hear you work on super bugs, which must be even more difficult. Can you tell us about some of the innovative work that's happening in LMICs?
Thank you for having me, and thanks for the question. More than 90% of the innovation that happens in the space, Rumbi, is done by small companies, small struggling companies that are barely alive, hypoxic for sure. That's because the big pharmaceutical companies have left the space there for lucrative areas. So you're now left with just small companies, a handful of them. And they're the ones who are doing the innovation, right? Maybe less than 30 people, 40 people. This is a very difficult space because we're dealing with a live organism that's much smarter than humans and that has evolved over millions of years. So the science is difficult and the business models are even more difficult. You spend a few $100 million, innovate a drug, and you want it to be kept under lock and key, to be used only on patients for whom existing drugs don't work. It makes no sense from a regular pharmaceutical parlance. So we are up against something really difficult scientifically because you are dealing with bugs that are so smart and evolving constantly, and you're dealing with a broken business model where you don't have volume. So you're left with the small companies, and thanks to Carbex, GuardP, and a few of these other wonderful partnerships that have happened post the last UNGA meeting, companies like ours survive. Else, BugWorks would have closed long ago. So we have made a lot of progress since the last UNGA in that way, that there are at least some mechanisms to promote innovation. Now, more than 80% of the mortality that Ramanan was talking about is happening in low to medium income countries. So, how do you innovate sitting in the West if we don't understand the resistance patterns or the financials that are required to make these products available where it's needed the most? So, what's happening, Rumbi, is something very interesting. If you innovate in the United States in AMR, it's 100% route to bankruptcy. 100% route. I'm sorry. It's just a fact. If you spend $200-300 million, you go through US FDA, you get a UTI drug that'll be used by a handful of patients. You can't even keep the lights on. Whereas there are patients on other part of the world, hundreds of thousands of patients who are dying for these drugs. So why not innovate and work with partners like GuardP and Carbex and others who are able to support innovation coming from low to medium income countries? So companies like ours, we are based in India, and we're trying to work on a completely new class of antibiotics, the first since the fluoroquinolones. I hope we succeed for humanity's sake and for our investors' sake. But the fact is, I think the low to medium income countries are not the troublemakers alone. Good solutions are coming, contextualized solutions are coming from where it's needed the most. The pathogens we work with in India, in South Africa, are tough pathogens. So if we can innovate new drugs where it's needed the most, in the battleground that it's right in your backyard, there's a good chance that those antibiotics will work across the world. A problem in India today will show up in New York in 7 years, or 5 years, or 10 years. So why not do the innovation where it's needed the most? So I'd like to make a comment that new innovation is likely to be launched in LMICs even before it's launched in the US. I think that's the only way forward, and we hope to be a case in point for that.
Thank you, Anand. And speaking about differences between LMICs and high-income countries, the Lancet recently published an opinion that actually says there's a divide in priorities between LMICs and high-income countries when it comes to AMR. The focus for high-income countries is on more research and development, while LMICs may need more mitigation efforts. How do we ensure that this agreement or this resolution that comes out of this high-level meeting caters to LMICs as well, Sally?
Well, the outcome document has been negotiated. They're going to sign it off tomorrow, but I am pleased to say it starts with we need to prevent infection. We need clean water, infection prevention, WASH. We need vaccines. It then goes on to access to antibiotics, the routine ones like Ramanan has talked about, and innovative ones. It talks about how do we leverage funding. There's quite a lot of funding in development banks that could be used for AMR, but poor countries don't understand that it's there or how to get at it, so we need to do that. So it is very focused on what the majority of the world needs. And one of the things that's in there that I'm very keen on is putting in place an independent scientific panel to review the evidence. I'm hoping, the British government's hoping, that this will end up in Nairobi, run by the UN Environment Programme, because that's where the problems are. Then the Secretariat will have that in their mind as they commission work and work with the experts from all around the world. I want Africa to own this.
Thank you. It seems like from what you're saying, Sally, we have a pretty good agreement on the table. But Ramanan, how do we keep up the momentum after this Thursday?
Well, I think the momentum is there because of some things that are hardwired into this political declaration. The things that we wanted in here, actual numerical targets, a 10% reduction in mortality, improvement in appropriate use of antibiotics, 70% of these being these access antibiotics that are the ones that should be used, substantial reduction in antibiotic use in animals, as Sally mentioned, an independent panel for evidence, much like the IPCC. These are all in that declaration, and not to compete, but I think we have a better declaration than some of the ones we had last year, and I think these are all very actionable. We're due to come back to the UN in 2029. It would be utterly embarrassing. Not that it hasn't happened before, but it would be embarrassing to come back and say we haven't actually met those fairly modest targets. Now, there is also, very rare for a political declaration, as folks here would know, to actually have a number on funding, to actually have an aspirational number funding national action plans, which LMICs were very keen on. So I think we've got all the ingredients that we need. We now need to take this forward into countries. This prevention agenda that we spoke about is all funded. Gavi has the money. Bilateral programs have the money for WASH. They need to focus on, appropriate for antibiotics. We're working to set up an access facility for existing and new antibiotics, which will then also help companies like Anand's, where there is a ready pathway from developing a drug to then first getting it into patients in LMICs at the same time that it gets into people in high-income countries. Today, and we did a study, last 20 years, the drugs that were developed, only about 15% of these actually make it out of 10 countries. They don't make it out of those 10 countries at all. And that's a mistake because the patients are there and the money is here, but we've got to connect those dots, because if we don't connect those dots, companies like BUGWORKS fail. So I'm very optimistic. I think we have momentum behind us, and if we stay focused in the way that we have over the last few years, this is a very solvable problem. That's the other thing I want to emphasize. This is not a difficult problem. We've got the tools. We know how to do it. It doesn't require like a brand new technology to do. We just need to keep going at it, and then we can crack it.
Thank you so much. Ramanan spoke about connecting these dots, and we're coming to the end of our session. So, Anand, I want to go to you. What kind of support do you need going forward?
For folks like us who are working on new drugs, I think having the mechanisms that Ramanan spoke about, where you start looking at a go-to-globe strategy, Rumbi, that means new innovation needs to make it everywhere, or at least where it's needed the most at the same time. It can't be stuck just in the West and then make it after 10 to 15 years, if at all, to other places. So mechanisms that allow innovation to go wherever the patient need is there is something that I think would be extremely important. And the national action plans have to be funded. And there are certain countries worse than the others. But these, just talking about national action plan, not funding it and not holding these governments accountable to these targets that Ramanan alluded to, these are the top two things. Because without prevention, anything that people like us do is waste, right? So we need prevention. We need to protect the existing antibiotics and have to invest in future antibiotics. This is our chance. 2029 is too far away. I think 2024, this is it. I hope the political declaration will move into action and we will save millions of lives. That's what we want to do.
Thank you. That's a perfect call to action for us to end this session, moving to action. And I hope in 2029 would have actually met some of those targets. Thank you so much for joining me.
Thank you.